Hello to all KGR readers. I am Enrique Gómez-Gómez from Reina Sofía University Hospital, and it's my great pleasure and honor to explain our research about the role of MRI before confirmatory biopsy in assessing the risk of prostate cancer progression during active surveillance. Firstly, we should remind that prostate cancer is the most common non-cutaneous cancer among men in developed countries, and owing the natural history of those classified as low risk, there is some concern regarding overdiagnosis and overtreatment in these patients. Active surveillance programs have been implemented trying to avoid this overtreatment without sacrificing the correct timing for curative opportunities. To improve the safety of active surveillance programs, some tools and risk calculators have been explored with different mixed results. MRI has evolved as a useful tool to improve the stratification and characterization of prostate cancer patients candidates for active surveillance. Results from different studies have proposed MRI as a predictive marker because of a higher proportion of reclassification in patients with suspicious lesions on the MRI. It has also been proposed that this better active surveillance candidate selection decreased the rate of progression during follow-up, as shown in ASIS trial. So the aim of our research was to demonstrate the impact of introducing MRI before the confirmatory prostate biopsy in two consecutive cohorts, without and with MRI before the confirmatory biopsy, and also to evaluate MRI as a progression predictive marker in active surveillance. For that purpose, 170 males were consecutively enrolled in an active surveillance program from 2011 to 2019. MRI was introduced before confirmatory biopsy from 2015 onward. Active surveillance inclusion criteria are shown here. As we can see, they were very restrictive criteria, so progression was defined as a Gleason score equal or higher than 7 or ESUP grade 2, and because of an increase in disease volume. Prostate MRI for confirmatory biopsy was performed around 6 months after the initial diagnostic biopsy and recommended before any follow-up biopsies. MRI examinations were performed using 1.5 Tesla MRI using 16-channel phase array body coil and interpreted according to PIRAT's version 2. Suspicious lesions was considered as a PIRAT equal or higher than 3. An initial systematic 12-core biopsy was performed in the diagnostic biopsy, while a saturation biopsy with at least 18 cores plus target biopsy was performed for reclassification biopsy and follow-up biopsies. For target biopsy, a sensor-based software was used to guide the biopsy to the target. Altogether, 170 patients were evaluated. The median age at diagnosis was 65 years. Median PSA was 5.30 nanograms per milliliters, and the median PSA density was 0.12. The majority of the patients were biopsy naive at diagnosis and with a clinical state of T1C disease. Reclassification rate at confirmatory biopsy was 36.5%. Here is shown the distribution of the reclassification pattern at confirmatory biopsy among the cohorts. 108 patients were included in the MRI protocol and 62 patients were included in the cohort without MRI before confirmatory biopsy. As we can see, those patients with suspicious MRI showed a higher reclassification rate in comparison to those without MRI and obviously those with non-suspicious lesions on the MRI. Clinical differences were observed in PSA density and in the rate of reclassification at the confirmatory biopsy between the MRI group and the cohort with no MRI. We also observed statistically but clinically marginal differences in the total length of prostate cancer, number of cores, and time to confirmatory biopsy. The percentage of reclassification at the confirmatory biopsy was higher in patients with suspicious MRI than in those of the other two cohorts, as previously shown. In the univariate analysis to determine the reclassification risk of the confirmatory biopsy, the age, the PSA density, number of biopsies before the diagnostic one, the inclusion of the MRI before the reclassification biopsy, a suspicious lesion on the MRI, number of positive curves on the initial biopsy, and total prostate cancer length in the initial biopsy were associated with a higher risk of reclassification, remaining the suspicious lesion on the MRI as the strongest variable. In the multivariate analysis, only PSA density and suspicious MRI lesions remain associated with the risk of reclassification. When evaluating the risk of progression during active surveillance follow-up, again, age, number of biopsies before the diagnostic one, number of positive cores on the diagnostic biopsy, the use of MRI before the confirmatory biopsy, or the presence of a suspicious lesion on MRI were associated with the risk of change to active treatment. In this scenario, only the age and a suspicious lesion on MRI were associated once adjusted in the multivariate analysis. In this Kaplan-Meier analysis, we can see how not only during the first year due to the confirmatory biopsy, but also during follow-up, both patients with suspicious lesions on MRI seem to change earlier to active treatments. All of these results should be interpreted with cautious, as there are some limitations. These results are from a single-center experience with dedicated genitourinary radiologists. This is a retrospective analysis. Rigorous adherence to the protocol was not evaluated, and it's known that adherence to repeat biopsies decreased with the time of follow-up. And finally, the use of 1.5 Tesla rather than 3 Tesla may have decreased MRI accuracy for the detection of significant prostate cancer. With all of that, the results of this research show that the inclusion of the MRI before the confirmatory biopsy is useful to stratify the risk of reclassification at confirmatory biopsy, and that the presence of suspicious lesion on MRI could also be considered as a putative prognostic factor for reclassification and progression during the follow-up period. Thank you very much for your attention.